So hello to everyone. We are here again for a new EasyChem chat. I have the pleasure to welcome a very good friend of mine who is very far, Jason Roberts from the University of Brisbane in Australia. Hi, Jason.
Hello, Fabio. University of Queensland, to be specific.
Queensland,
and,
yeah,
it's
you're right.
wonderful to see you again.
Yeah.
It's a shame that I haven't been able to visit your hemisphere or your country for too long.
Yeah, thanks, Jason. Jason is a worldwide recognized expert in the, let's say, antibiotics pharmacokinetics and antibiotic dosing. So the topics today will be a little bit how to optimize dosing of antibiotics in critically ill patients. The first question is, which are the patients in the ICU who are at risk of underdosing of antibiotics?
So it's a really good question. It all depends on what your approach to dosing is. Typically in observational studies where we're just looking at a normal approach to dosing which is used, it tends to be patients that have either very high renal function, those that we would describe with a term called augmented renal clearance. So they have a creatinine clearance which is at least above 130, and they tend to be quite common. And those patients incorporate neurotrauma patients, but also other multi-traumas, pancreatitis, burns, febrile neutropenia, amongst others. So there's many types which fall into that category. Most of them tend to be quite young males with a normal serum creatinine concentration. So that's one group. Other groups include patients receiving renal replacement therapy, whereby their initial dosing is immediately adapted to a renal replacement therapy dose. And so there isn't a sufficient exposure for that. Their volume of distribution changes, etc. And that can also happen in ECMO patients too. Typically in the latter two patients, it ends up being later on in therapy that's not a problem, but we tend to see a delay of at least 48 to 72 hours of them getting to a therapeutic concentration. So that'd be classical groups which would end up with low drug concentrations.
And in your opinion, how we can avoid this early underdosing these patients at risk? Is it a matter only of the loading dose? It's a matter of loading plus subsequent doses?
So it depends on the drug, and it also depends on the patient. And so if it's that scenario where I referred to like a renal replacement therapy or ECMO scenario, they tend to have reduced drug clearance, generally speaking. And so they just need a higher initial dose to get them into a therapeutic concentration. And then you just maintain standard dosing for those patients and, they'll be fine. Whereas for patients that have high renal function, not only do you need a loading dose, but you really do need higher than standard dosing, because dosing regimens, which you find in the product information, haven't been designed for patients with very high renal function. And so a new dose needs to be used in those patients, which accounts for that physiological manifestation, which is associated with the trauma of being in ICU.
I think that we all agree that the message of underdosing has been clear in the minds of physicians, because we tend to prescribe higher than recommended doses, at least in the early phase. Now, of course, many people who are more skeptical would wonder whether this, insufficient drug concentration really result in a clinical harm for patients. Which are the data or the evidence we have suggesting that we should do something to avoid underdosing?
Yes, I mean, like the data to quantify the effect of underdosing on patient outcome is really quite a challenging thing to do, because no one's really been brave enough to do a randomized controlled trial of underdosing versus, therapeutic dosing. And of course, that kind of makes sense. No one wants to deliberately undertreat. And so most of the data comes from observational studies, and they have defined essentially a threshold whereby you have a higher probability of treatment success if you achieve a particular exposure than a lower exposure. Classic example, which is often quoted, is for a study from McKinnon et al. In 2008 with cefepime and ceftazidime in patients with lower respiratory tract infections, showing that if you achieved 100% time above MIC, that you had something like a greater than 80% likelihood of clinical cure. But for anything less than 100% time above MIC, then you had a 30% likelihood of clinical cure. So of course, it's not as simple as you achieve a concentration and then you have, a guaranteed, positive clinical outcome. It is on a linear scale, and it all does depend on what the pathogen is, how sick the patient is, etc., what the site of infection is. But generally speaking, these observational studies, which traverse all the different antibiotic classes, pretty conclusively demonstrate that concentration does matter.
Of course, the other side of the story is that as we're giving higher doses of antibiotics, we observe, you have done with the using, therapeutic drug monitoring, we have the same experience. We have more and more patients with very high drug concentration. So we know that there are side effects for aminoglycosides and vancomycin, for example. Do you think that there is a risk of overdosing and some side effect also for commonly given drugs, like, for example, beta-lactams?
Yes, this is something which, you're exactly right and becoming increasingly apparent. I'll admit that I don't feel like I see a lot of neurotoxicity for beta-lactams in my own clinical practice. And I think that is because of our beta-lactam TDM program, which allows us to really quickly reverse our dosing. But certainly there's an increasing evidence from observational studies showing that high beta-lactam concentrations are associated particularly with neurological toxicities, which could be as simple as encephalopathy, but could also be seizures. And there are some drugs like cefepime whereby the data is quite strong for it, and it can be trough concentrations as low as 21, but more recently closer to 50, and other papers 70, which are associated with emergence of seizures. So essentially, beta-lactams, although we would previously have thought them to have a wide therapeutic range, they do have a therapeutic range. So there is a ceiling whereby we can't go above. And so although many groups like yours and mine over the years have been saying we can't underdose patients, a lot of people may have taken that to heart and they just say, well, let's just use really big doses. Let's not adjust them in the context of renal dysfunction or renal replacement therapy. And that unsophisticated approach does increase the likelihood, therefore, of those patients having very high concentrations, which of course means that you're testing that upper boundary of the therapeutic window. So yes, it is potentially problematic and it will prolong length of stay in the ICU. That's certainly something which would be my observation because, as I said, I haven't really seen much in the way of seizures, but I do feel in renal failure patients that if I see a high drug concentration, that they do seem to be encephalopathic for longer, which more often I relate more so to the antibiotic than other drugs that they're on. But of course, the other drugs will be contributing as well. So
of course,
bottom line, yes.
Yeah. Now, another point where many people approach this antibiotic dosing word, I always this question from people saying, "Are you really sure that the threshold that you use to define is sufficient overdosing, at least for beta-lactams?" Because for aminoglycosides, we use literature existing from before, from a lot of those studies made in the 80s and 70s. What about beta-lactams? Are we sure that what we indicate as insufficient or excessive are really the threshold that everyone should use, or there is still some controversy about that?
I think there's still some controversy, mainly because I don't think that there's one threshold which covers all clinical indications. I think that an extreme example would be a meningitis versus a skin and soft tissue infection, which isn't a severe one. Like you don't need the same drug exposure for both of those. And so having the same target for both doesn't make sense. And so as soon as people start to look at trying to describe, well, what is the threshold, for example, for sepsis? Well, sepsis is a constellation of any different number of indications for use of an antibiotic, of which, they have a consistent syndrome, but still, where the source of infection is, could be anywhere, and whether or not a blood concentration reflects what the concentration is at the site of infection is a completely different matter. And so I think that that's part of the problem. People want just one value to look for, but I think it's a little bit more complicated than that. And that's why in our practice we sort of apply a couple of different targets. If we think it's a site whereby the drug penetrates well, we're happy with maintaining a concentration above the MIC through the whole dosing interval. And I'll come back to that in a second. Whereas if it's a really deep-seated infection, maybe like it's a central nervous system infection or it's a really severe lung infection, then we'll aim for maybe 4 times the MIC throughout the whole dosing interval. Now, some people would say that, look, I think that the laboratory-based literature, the animal models, the in vitro models suggest that you only need to have 40 to 70% time above MIC, depending on your beta-lactam. I'd say, look, you're probably right. But at the same stage, in terms of performing TDM and to have a target, I find that 100% time above MIC is an easier target to practically implement, and it doesn't make that big a difference really in terms of what the actual dosing will end up being. So for us, that's a pragmatic solution. But it is a complicated scenario, and I don't mean to be saying with each of these answers that it's complicated, but it's like all things in medicine. You've got to look at the patient, make an individual judgment for what their requirements are, and then use your best judgment or facilities that you have around you to get to that endpoint that you're after.
Now, imagine that people want to take everything you said and would like to adjust antibiotic dosing at bedside, but they do not have TDM. Can they use clinical information, like as you said, renal function, obesity, ECMO, RRT, or there are softwares that can help? If there are softwares, are they validated for critical ill patients?
So firstly, in terms of what patient-specific indicators are there, well, I think the renal function, for most antibiotics, is definitely the best option because, there is a strong relationship for almost all antibiotics, all the renally cleared antibiotics anyway, and creatinine clearance. And so that's why numerous groups, including yours, including mine, have developed dosing nomograms, which really find a relationship between creatinine clearance and a drug dosing requirement, and then you can read off the nomogram and it can tell you what dose to use, and that's going to get you pretty close, certainly closer than if you just used a product information dose. So that's it's a better approach. Whether or not it's possible to use something like dosing software is something which is currently being explored, certainly in silico, which means via computer simulations it does perform better. And the reason it does is because essentially it has not only a nomogram for a singular covariate, such as renal function, but it's able to take other covariates into account as well, such as body weight or the MIC of the organism or whatever. And it's able to take multiple variables in and use that to make a calculation for what the dosing requirement is. Now, it's still not perfect because there's so much intrinsic variability in the system, but it does get you closer. But whether or not the effort that's required to put all the data into the dosing software, it can give you a better, health impact in terms of, patient outcomes, improving length of stay. That hasn't really been established. But in terms of something that kind of makes sense, that should be investigated further, that's definitely the case.
Okay, I have a very last quick questions. Many people criticize that the TDM of beta-lactams, for example, is not still available because of many limitations that we know. Which would be the characteristics of a future TDM system or device to be routinely implemented in all ICUs?
So if you could get a measurement system, which is like an arterial blood gas machine, whereby you just take a single 1 ml drop of blood, or maybe like a little micro sample from like a dry blood spot, and you put that into a card into the machine, and it tells you either dose good, dose bad, or concentration high, concentration low, concentration good. And even better, if that could then feed back into the electronic medical record, which then draws in all the renal function data, the infection data, and says, this is the new dose the patient should be on, like that'd be great. But we're not quite at that stage. There's quite a few new technologies coming through, which are trying to make it such that we don't have to use those really expensive chromatography-based laboratory systems to analyze the drug. But, they haven't really made it into proper testing yet. And well, certainly the results haven't come through in the literature yet, but I expect that in the next 10 years that, that we are going to see some really interesting results, because I know there's a lot of activity in this field.
Jason, really thank a lot for your time and your availability for this e-chat. I really hope to see you maybe face-to-face in the future, and of course, people in Europe and elsewhere to hear about your lectures in this very interesting topic. And of course, take care and see you next time.
Thank you, Fabio. Thanks. Great to see you again.